on to module number 2. We're going to talk about imaging approaches with CT and MRI. We'll first talk about computer tomography. Here's a typical CT scanner where you have a donut-shaped round structure, and then there's a bed that will slide inside and outside of the gantry to acquire data by the CT, and then it's reconstructed into images that we can interpret. Now, these days, almost every competent scanner will be multi-slides. That means that there are more than one detector row, and as the detector wraps around patient, it will require more than one slides of information. And the number of slices that can be reconstructed could be anything from 4 slides to 320 slides. Now, cardiac imaging requires the machine to do a little bit more. Now, in the spiral modes, you can imagine that the body is sliding through the scanner while the detector trace out a spiral-like or a ribbon-like wrapped around body. And as the table translates along the z-axis, time also progresses. So you can imagine that as the table progresses, there's also EKG activity that's going on in time. Now, the way the CT reconstructs cardiac synchronized data proceed as follows. Most of the time in cardiac tumor application, we will use what we call retrospective gating mode. We will have a very low pitch progressions of the scanner. And I plot here a plot where there is in the x-axis time and the y-axis the table positions. So these dotted lines here trace out for an example of 4 detector slides as it progresses in space as they go over in time. Now, let's suppose that you want to acquire certain data from a slides position from here to over there. The machines first scan the data, and then retrospectively it laid down the EKG information that it recorded concurrently. And then on every single cardiac phase that it wants to reconstruct, it will look through the data from this slide to that cardiac phase where the data is within the detector row. It would grab the right amount of detector data from the correct detector number and reconstruction for that slides. Now, by reconstructing different slides position and reconstructing a different cardiac phase, it is possible to do a 4-dimensional reconstruction of the heart using CT. And by doing so, you can actually look at the tumor, how it moves inside the heart, and where is the major structures that it might be close to, such as coronary arteries, such as the valves. A typical cardiac CT protocol is as follows. Patient always have to have a IV. We typically ask for a 20-gauge IV. The patient will need to have EKG lead placed for the cardiac synchronized scan. We might start with an optional non-contrast scan, and we will typically do this with prospective gating. This is a different mode of gating where it uses less radiations. We typically reconstruct a 3 mm thick using the soft tissue kernel and display in the soft tissue windows. We do this optional non-contrast scan primarily to assess any calciums in the tumor and to do some simple measurements of the fluid collections to see whether it's simple or complex. Now, then we perform the contrast-enhanced CT angiogram. Typically, we give 1 to 1.5 milliliter per kilogram of contrast volume. We set up to trigger, use bolus trigger at the aorta. Now, we want to make sure that the injections is long enough by by adjusting the injection rate to make sure by the time when we trigger in the aorta, we still have contrast in the right ventricle so we can light up the entire heart and to evaluate the mass either on the left or right side. We perform a retrospective gating mode of scan, just like we just discussed. Then we reconstruct the images in 1 mm thickness, and then we construct a soft tissue kernel and again display in soft tissue windows. Now, optionally, we might perform a post-contrast CT of the chest, and here we'll scan the whole chest, not just the heart, at about 30 or 40-second delay after the end of the CT angiogram. The reason for that is because sometimes we would like to survey for any other locations of either tumor that had metastasized out from the heart or a tumor that originated from outside and had metastasized inside the heart. So this is a way to look at the entire chest in total. Switching gear, we're going to talk a little bit about magnetic resonance imaging. Now, there are a couple basic sequences that we use. Again, I'm going to go through them very quickly and then to set down the name because we're going to use those names for the rest of our clinical cases. So the workhorse of cardiac imaging in MRI is the balanced SSFP sequence. The SSFP part stands for steady-state free precessions. Typically, this sequence shows the blood as bright. You can see the inside ventricle, the right and left ventricle with this short axis plane. It is bright. It is a cine, so usually it means that it has 10 to 20 cardiac phases that are being played as a film loop so you can see the motions, contraction of the heart. This sequence does not require IV contrast, and that's kind of nice. It has a mixed T2 over T1 weighting. Another sequence that we use a lot for cardiac mass is the dark blood sequence or black blood sequence. It is a cardiac triggered sequence, so you have to specify exactly what cardiac phase that you want to image. It will produce only that cardiac phase, so there's a single cardiac phase acquisition and there's no cine. Again, no IV contrast is required. Usually it is imaged with a fast spin echo type of readout, but the front part of it is called double inversion recovery. Sometimes you'll see that the word triple inversion recovery, it is essentially a fat suppressed version of a double inversion recovery. So here's an example where you can see that fat in a double inversion recovery is pretty bright and the myocardium is great, intermediate intensity. So it does give you a fairly T1 look of the heart. Now, by manipulating different parameters of the double inversion recovery or the triple inversion recovery, it is possible to get additional manipulations of the image contrast quality. The most important one is fat suppressions. Here's an example of a mass that is at the anterior wall, and you can see that there is a very bright signal, as bright almost as the dermal fats. But by turning on the fat suppression and see the dermal fat suppressed, this mass also immediately suppressed. So it tells you that this is a fat-containing lesion. So fat suppressions on top of the double inversion recovery is an extremely useful technique. Now, by changing the number of RR interval for your repetition time, TR, as well as adjusting the echo time TE, it is also possible to obtain different weighting. For example, this top image here is obtainable to T1 weighting, or somewhat proton density weighting, depends on how long is the cardiac period. So if the heart rate is very low, typically your TR time is going to be long anyway, so they end up being proton density weighted. Now, by making TE long, it is possible to get T2 weighting, and typically we do this in combinations with fat suppression, typically with triple inversion recovery. So, by the way, this mass, we're going to see that later. This is a typical myxoma. Now, one benefit that MR and CT has is that we have ways to look at the vasculature outside of the heart, quite often may be involved by the mass. So here's an example of a patient with an extremely attenuated right pulmonary artery, and this is delineated with a MR angiogram at the pulmonary face. This turns out to be a chronic PE, but if the patient has an aggressive angiosarcoma in the pulmonary artery, it could have similar appearance. We'll call this simply as contrast-enhanced MRA for the purpose of this talk. Now, one of the very unique aspects of MRI is that we have ways to image velocity in a similar functional sense as echocardiogram during Doppler imaging. Typically, we will do a cine type of imaging where you can see that there are multiple images being strung up and looped as a movie. We have the ability to encode the blood flow in each voxels in 3 directions. So it is possible for us to tell in not just the magnitude of how fast things are moving, but which direction it is moving. And we're going to call this the phase contrast cine. Now, perfusion imaging is sometimes quite important for lesions that somehow have a very hypervascular structures, such as angiosarcoma, hemangioma, and some of the neuroendocrine tumors. And in those cases, the enhancement can be so fast that it helps differentiate from some other more slowly perfusing masses. And so we do this by perfusion imaging. And typically, we have a first pass contrast going through the body from the right side to the left side heart, out to coronary arteries, and from coronary artery then enter the heart. If there's a tumor, we'll compare the enhancements of the tumor relative to the ventricle blood pool as well as to the myocardial enhancement. Finally, we will talk about delay enhancement. Delay enhancement is a special technique where the myocardium itself is suppressed deliberately. So any abnormal signal in the myocardium will jump out bright. And here's an example of a patient with a left anterior descending artery infarct, pretty extensive. And these infarcted area now retain contrast and make it very bright. Now, in tumor, and some of the tumor will retain contrast just because the capillary is leaky with its disorganized entry into the mass itself. So it could retain contrast, and one prototypical example would be fibroma. It had a very avid and very striking appearance in the delay enhancement. By the way, on this image right here, you can actually see our first mass. Here is a very dark structures sitting inside of the anteroseptum anterior wall in mid-ventricle. This turned out to be a thrombus that is stuck in a relatively mobile part of the left ventricle. Now, there's no single set cardiac MRI protocol. The reason for that is simply because the tumor can be anywhere, and you have to adjust your imaging approach based on what view or planes will present the mass in optimal fashions, and then you have to adjust your scanning protocol to reflect that. But typically, there is a certain pace to it, so I'm going to go through it with you and give you the rationale why some of these sequences are included. We'll usually start to localize it just to figure out where the chest is, and then we'll do a survey of the chest and just to find out all the big issues that we will have to follow. And typically, we'll do this with an axial single-phase SSFP sequence. Once we transform in the cardiac axis, we'll do survey of the entire heart using SSFP-CNE in two planes. We'll do this in the short axis all the way from the atrium to the apex, tip of the apex, and then we'll do a horizontal long axis, which is equivalent to a four-chamber view. Again, include the whole heart from the very top to the bottom. So with these two axes, we usually should be able to bracket the mass, know exactly where it is, and know how it moves. Now, you might need additional cardiac planes as needed. If there's a unusual structures that doesn't line up very well with those two axis planes, you'll have to judiciously choose what will show it better. Now, after that, what we're going to do is to characterize the mass. So we don't need to survey the whole heart anymore. Hopefully by now you know what a mass is and how many there are. And for each mass, or one mass, solitary mass, if there's just one, you need to do some imaging just across that mass to find out what is T1 behavior, what is fat suppression behavior, and what is this T2 behavior. And we use the sequence we just discussed. These are double IR fast spinacal and triple IR fast spinacal with T1 to T2 weighting. Now, after that, I usually do a whole chest axial 3D fat side T1 weighted pre-contrast images. It's a fairly fast sequence, a single breath hold, and gives you at least some information about native hyperintensity value that is outside of the heart. And then after that, I'll proceed and go and do a myocardial perfusion scan. Again, I would opt to do the perfusion scan over the contrast enhanced MRA if you can only give the contrast once. Both of these are first pass approach, unfortunately. But let's say that you do have vasculature that you need to evaluate and you know that it might have an arterially enhancing tumor, then I would do the myocardial perfusion scan first. Again, using the plane that would shows the mass best, and then I'll give a second dose of contrast to go ahead and do the contrast enhanced MRA. Once the contrast is on board, I'll go ahead and do the post-contrast survey for the entire chest, again, to 3D fat-sided T1 breath hold sequence. After that, with the appropriate delay, I'll go ahead and do the myocardial delay enhancement. And if the structure is obstructing any critical areas, such as, let's say, the inflow valve or the outflow valve, or the inflow of the venous structures or the outflow to the great artery, as in the left ventricle and right ventricle outflow tract, I might elect to do phase contrast imaging to see how fast the flow is, trying to get around the obstructions and try to measure the cardiac outputs. These might have significance to how urgently you need to do the study and just do the surgical treatment. Depends on how much of the cardiac function is compromised. Now, what follows, I give you two tables, one of them for the adult tumor, and this lists various characteristics, how mobile the mass is, the common locations, T1, T2 weighted signal, and delay enhancement or contrast signal. This is a table for the adult tumor, and here's a similar table that's structured for the pediatric tumor. And finally, almost everything that we do on CT volumetric acquisition as well as MR volumetric acquisition would need to have competent 3D post-processing workstations. Quite often we have to reorient our slides to highlight the mass the best we can. So 3D post-processing is absolutely crucial. Okay, thank you.